Secretion.
Besides pain, secretions, and anxiety? Or,
Nausea?
Nausea is a common one.
So constipation is another really
Constipation.
big one for parents.
Oh, right.
They're very distended, they have respiratory distress, they're uncomfortable, and so a lot of attention is paid to bowel regimens and to making the kids comfortable. Dyspnea is another thing that parents in particular find very distressing. And so morphine is very, very good for terminal, particularly dyspnea, and helping the patients breathe comfortably. And we often will add some phenobarb, neither of which shorten the patient's life, but really improve the patient's symptoms. So before we, for example, compassionately extubate a patient that we think is going to be gasping and having this irregular breathing, we'll give them a little dose of phenobarb, 3 to 5 milligrams per kilo, and they will just sleep comfortably, and we'll give them some morphine for pain, swab their mouths, or put a couple of drops of atropine in their mouth so that the parents don't have to hear the rattle. That is so distressing. And that seems to have been pretty helpful. And I think it's important because a lot of nurses and doctors in particular are afraid that if they give morphine, they're going to kill the child. And it's well shown that if you manage their symptoms well with morphine and midazolam, children often will live longer and better and die better lives than if you just leave them to struggle through the end of life.
I will add that in my experience, most of the kids that were still taking nutrition and medications orally would often end up with constipation because the bowel regimen, as in one child's words, is disgusting, and they don't like to take it. So they will often end up constipated because everybody who's on the pain medication regimen is on a bowel regimen as well. And what we found in another place where I was working is that they weren't being assessed for constipation because everybody knew they were on a bowel regimen, but nobody was checking for compliance, and there was very little compliance if they were taking the medications orally. The palliative care team, we're a Monday through Friday consult service. Right now there's only the 2 of us. Our social worker is on emergency leave. But that is our main phone number and pager, Dr. Newman's phone number and pager. And if we're not available in the moment, please do send us a note. And we can follow up, especially if the child has gone home. We are available for staff support as well as for patient reviews. You know, especially if you have had a difficult patient that has caused a lot of moral distress with the staff. We're here to support both the patient's families as well as our staff.
Do patients' families ever call you directly?
Yes.
Okay. So what do they do on the weekends when they have a problem? Saturday, Sunday?
They usually get the social worker on call, answers for palliative care.
Okay.
Yeah.
And I will usually carry a pager if I'm in town, or phone if I'm not in town, and will answer on the phone. But I don't give my direct number to patients. But I would hope in the next 10 years, could have a vision to have a secure service where families could FaceTime or the equivalent of FaceTime in a secure manner and call from home and have education for the pediatricians who are taking care of the patients, so that we don't have to have patients coming to the emergency room, but that their private care doctors or local nurses would be able to be physician extenders and we could work with the hospice and palliative care out-hospital teams. For example, in Alameda County, correct me if I'm wrong, we just recently got access to concurrent care with the Alameda, what is that group called? The
Hospice by the Bay.
Hospice by the Bay. And so they've been really helpful. And there's, I'm blocking now because I'm tired, but there's a
Fetus?
now what's the in each county there's something for palliative care, do
The palliative care waiver?
they? Yeah, right.
It's not in every county, but it is now in Alameda and parts of Contra Costa County. So these are two forms where children can get support services if they're Medi-Cal and have the services covered. With concurrent care, the children, okay, so let me backtrack a little bit. In order to receive hospice in the United States, you have to forego life curative or life prolonging therapies, and a physician has to state that they think you would die within 6 months. Okay. That was a significant those two things were a significant barrier to hospice care for children. Parents were not going and were not giving up on life prolonging even if they knew there was no curative treatment. Having a 6-month prognosis for children can be difficult because children are very difficult to prognosticate. Look at how many kids should have died when they were a year old, and you know, Charlie, whose picture is in the cafeteria, just went to the senior prom. So concurrent care came about with the Affordable Health Care Act. So in 2010, for children only, if they had a prognosis where you would not be surprised if they died within 6 months, they would be eligible for hospice care and would not have to, do not have to give up any life curative or life prolonging treatment. So if they've got home nursing, which is the biggest one, they don't have to give that up. Before they had to give it up. And of course, hospice doesn't provide home nursing. So now they get to keep all the services that are already in place and add the services that hospice brings. And hospice brings a lot of the supportive services, spiritual care, social work. If it's a pediatric hospice, they usually have child life, et cetera, for the patient as well as the family. So they do a lot of anticipatory grief and bereavement support. So that's concurrent care.
That's a national?
That's national.
So I'm a little bit confused. I want to ask a question here. So do you is there a palliative care clinic?
Not yet.
Is that the goal? So like, I mean, so my mom was in palliative care, and they had home health nurses that came in and managed her, blah 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 blah. Then they transitioned over to hospice. So what is our palliative care team? How? Like, so we call you up. We say, well, I think this kid's a good candidate, and you folks come down and evaluate. And then you decide that they will come into our palliative care services. So from that point on, how do they get access to you? How do you guys examine them? How do you find out about their GI issues and
We
their
work
pain?
with their primary physicians, their primary care providers. We help to coordinate the continuum of care as far as the identifying the goals of care for that patient and that family. Ensuring pain and symptom control. So Dr. Newman will work very closely with their primary care physicians.
So are you guys just mainly working on in the inpatient setting?
Right now, it's primarily in the inpatient setting,
all right.
although we do home visits as well. And all of our patients, once they get discharged, can still call us and,
So they would, so like, the parents would call in the 9 to 5, Monday through Friday, they would call this number and get a hold of you as social services, Dr. Newman, and then you guys, they would say, they're doing this symptom, so and so, and you guys would write a prescription. And
we wouldn't write the prescription, well, we might write she might write the prescription, but we would talk to whoever was providing care. Oftentimes we will help coordinate the home care.
I see.
and the palliative care team that would visit the child in the home. We've done a lot of work in training, like Vitas was an adult-only palliative care and hospice program. They now have a pediatric program, so we've done a lot of training to help them get there.
I see.
Hospice by the Bay has always had a pediatric program, but was not in Alameda County. They were in Marin, San Francisco, and parts of whatever is above Marin. But because we actually had no providers for pediatric care in the community,
Right.
they actually went, it took, 18 months, finally got licensed and approved to provide care in Alameda and parts of Contra Costa County, and just got their very first patient 3 weeks ago in
So-
Alameda.
So if somebody's at home and they need, we've started the palliative care, we've consulted, and they're at home, and they have some certain symptoms, how do you guys see them? How do you get access to them?
So we, if they're outpatient and family calls me and says, we're having terrible pain problems, or
Right.
constipation problems, or breathing problems, I would probably call the pediatrician, ask the pediatrician to see the patient, call me, describe what they want, and we talk about a plan,
Okay.
a management plan. The vast majority of these patients are also in specialty care, so they'd be in neurology, pulmonology.
Mhm.
You're kind of the liaison between all of the different
Mhm.
specialties
Correct.
that are taken care of.
Yeah. And so, for the most part, if they're an oncology patient, they'll be calling oncology, and oncology might call us and say, what do you think about this, that, or the other?
Right.
It's not the ideal. If a patient is really sick and or is homebound, we very likely would have referred them to Hospice by the Bay or Vitas for concurrent services, and they have their own physicians who are involved, and social workers and nurses who are involved with the patients, and then they collaborate with us, and we have a consulting kind of service. It's very hard to run a really robust palliative care service unless you have a significant number of staff.
Right, yeah.
But I think we've made tremendous inroads, and the points you make are all excellent ones.
They are.
And ones to which I think we would aspire. You know, ideally, we would want a chaplain as part of our
Right.
team. We have a wonderful chaplain in this hospital, but she's pulled in a million different directions. And palliative care patients really need a lot of, and their families need a lot of spiritual
Spiritual, yeah.
support. Ideally, we'd have a psychologist as part of the team, a child life person as part of the team, ideally a music therapist, on and on and on, right? But
Right.
resources are limited, and I think our number one goal is to educate all of you so that you can embellish your knowledge and feel comfortable making some suggestions to families when you talk to them in the ER. If you see mom coming in and she starts talking about how, gee, constipation has been such and so a problem, that you could say, I'm going to call up and speak to my attending, and you know, you might speak to Kevin, for example, and he'd say, yeah, that's not really an ER problem, but you'd be able to tell the parents, and maybe call us and say, this patient is in palliative care having a lot of problems, or is not in palliative care having a lot of problems, and I might reach out to neurology who sees the kid every month.
Right. Okay.
That sort of thing. But I really feel like families confide in nurses in a way that
They
they
do.
That's true.
rarely confide in families,
That's true.
in their doctors.
That's true.
The doctors run in, they do whatever they have to do, and they run out.
Sure.
And then they're typing half the time anyway. But I think families are so eager to have support, and they really trust the nurses. And I found in my little travels that the nurses have added so much to my knowledge of, you know, this family really doesn't want all these things. Are you aware of all of this? This is what they told me. I had no idea.
Well,
So to your point, that is exactly the primary function, is to bridge between all of the subspecialists, the community, and the hospital, and make sure everybody is aware of what the goals of care are. And that's decided by the patient and the family.
think any families are resistant to engage because they associate palliative care with end of life? I don't know if this is something you discussed
No,
before.
it's a definite issue.
And I think a lot of it is how it's presented. A lot of times, when I, in the ICU, for example, say, I think that really we can provide more support for you and hopefully help you coordinate stuff, because it's been really hard what you're dealing with, right? Yes, vigorous nods, you know, tears start dripping down their family's eyes, because it's really hard to deal with a child that's got so many problems. Would you be interested in meeting somebody who could maybe provide a little bit more support and coordination and help you with access to resources in the community? Yeah, we'd love that. Well, you know, here at this hospital, the palliative care team does that. Let me tell you what palliative care is. Yes, it used to be about end of life, but that's no longer our focus. And once we get past that chatter, I think if it's introduced as support and additional services, not which we're ready to cut off your child's life, almost every family will really want what palliative care is. Now, there'll be some who will say, no, I'm not ready for that, because they've already got a lot of preconceived ideas, and then I would back off and say, okay, that's fine. And there is some talk and negotiation, and I'd really like to hear people's feedback about changing, having a palliative care team have two arms, the supportive or umbrella arm and the end of life arm, so that families and people wouldn't have to choke when they say the word palliative care. And I don't really think it matters what you call it. If families get the best that we can offer, who cares what you call it?
I think that's part of the problem. It's not only educating your healthcare providers, and I think the setting of an emergency room with very fast turnovers, ambulatory, and it's no fact that, everyone knows that the nurse who puts you in a room, you may see one or two other nurses because, they're called to other patients or other needs, traumas or conscious sedations. But I think what's really important is so that we can quickly identify it and make sure that, since a lot of energy is put into these families to accept the concept of palliative care and what it has to offer, that families be educated to feel okay when they come to an emergency room, say, if they don't have their piece of paper saying, but saying that we have palliative care. To me, that's a nice red flag, and oftentimes a triage nurse, we have a triage note and just a quick type thing saying patients in palliative care. I think it's kind of like a nice little red flag to let us know, because things turn around fast, and anything to help us, to expedite that care or even make people aware, I think is very important.
I thank you for saying that. I think that's really true. I also want to say that we have to be very careful about giving mixed messages to families. If the doctor, for example, believes that palliative care is the end of life care, and the nurse starts talking to the family about palliative care services, and then goes and tells the attending room, this patient is really interested in talking about goals of care, and maybe they give me the sense that they'd like to talk about some other things, and the attending says, no, I don't think so. I think that they're nowhere near the end of life, because I hear that a lot of times.
I think that's the two things. When people hear palliative care, especially originally it's an adult model of care, people think end of life and pain management. So now that there's a pediatric wing of that, I think that kind of perspective, or the stereotype of what palliative care carries on, and that needs this education,
Absolutely.
Any other thoughts or questions?
How was your experience with palliative care?
It was good. It was very good.
What was the most meaningful thing to you? If I may ask.
I felt like they were really about quality of life. Giving my mom all the energy she could, figuring out. It's really it was about a quality of life until it was into the time for her. Her breast cancer came back really quickly. So and it paralyzed her because it landed in a tumor in her spine. But they were really about quality of life, like keeping her really comfortable, keeping her energetic, keeping her fed, keeping her so that she poops, and and that. And she really, we have a cattle ranch, so she really wanted to get out on the cattle ranch and get around, while she could. And so they were really good about that, like really finding ways to. And they had the home health nurses come in and manage her and that kind of thing, so we got to do it at home, which is great. And they did they got us all this equipment, home equipment. When she was paralyzed, they gave us a Hoyer lift, so we could get her out of bed into a wheelchair into the car. Like, it was incredible. So she got to go have some fun, before she died. So that was good.
So I think that's something that we often kind of forget, is to ask either the child and or the parent, but particularly teenagers and older children who can understand what's really important to you.
Yeah.
What do you want? What is your goal? Maybe cousin is getting married in 2 months, or prom is happening in 3 months. I really, really want to be there.
Yeah.
But if we understand that, we'll address that issue and try to make it so. Or I really always wanted to go to Disneyland. And patients who are within, I think, a year or 2 years and have chronic conditions, Make-A-Wish is a fantastic foundation. So if we find out about these kids, we can help them really achieve some of their goals. We're going to see the Chicago Bears, Cubs win the World Series. I know I send a kid there. So, and then just taking family pictures. We have moment by moment coming to the hospital. So there are a lot of things that we can do that can enhance a child's life. So I'm sorry, but I have to.
No, that's fine.
Thank you all for letting me come.
Thank you for coming.
One thing I wanted to show you was on the K drive, there's a palliative folder. And in that folder are the policies for the Post, copy of the Post if you need it printed out, and the reflection room. Do y'all know about the reflection room?
What's the
Where's
K
it located?
drive?
Right, K-drive.
Where's the K drive?
What is the K drive?
When you click on computer,
Right.
it comes up with the different drives under computer, and the K drive is one of them.
Do you have an icon under, like some of our?
We don't have an icon.
Maybe at
You're
some
not
point.
hooked into the computer system here,
No,
right?
I'm not
Yeah.
there.
So when you go back, if you're on the computer, it's not on the home page. You have to actually go that world thing on the far left on the bottom.
Right.
You click on that. Computer is on that right side of that box. You click on computer, and it'll show you the C drive, which is the hard drive of the whatever PC you're at, and then the other network drives. K is one of the network drives. It's a shared drive. So lots of different departments have folders on it. And then there's one that's called Palliative, and that's where all the policies are, and some resources.
What does POLST stand for?
Physician's Order for Life-Sustaining Treatment.
Okay.
Is that used in an adult too, or is that
It's for anybody.
Sustaining
and
treatment.
it's, okay.
It's the same form for children and adults.
Okay, and it's different from like DNR.
DNR are, what we use here is Allow Natural Death, A&D, is an inpatient order.
Okay.
What you might be thinking of is what used to be called the out-of-hospital DNR form. That no longer exists in California. It was replaced with the POLST form.
Oh, so that's California thing.
In most states, it's now the POLST form,
Okay.
and except in Michigan, it's the MOLST form.
Of course.
Okay.
So, yeah, but that's what it used to be. And this one allows them, there's pros and cons. This one allows them to say exactly what they want or don't want. So you might get a POLST form which says, I don't want mechanical ventilation, but I want compressions, or I don't want compressions, but I want mechanical ventilations.
That's specific, huh?
It can be.
Oh.
It can be. Some of them are just, no intubation, no compressions, comfort measures. But some of them can be very specific. And in that specificity, for some healthcare providers, it can be conflicting.
I hate to say it, but I wonder if having a little binder for palliative care, so that, I mean, there's only a small number of nurses here that
When you put
attended
it in
this,
the
but maybe.
same binder as the pulse and all that stuff, so everything's in
Right.
one binder,
Right.
I think identifying what it is, definition, I think would be helpful. Also, where's your reflection room? I've heard of that.
The reflection room is right where our offices are. It's on the second floor, right next door to the chapel, and across the street, and across the hall from the Bertha Wright conference room or boardroom.
The ED
Oh.
is, well, I haven't been here that long, but
Yeah, we have
so I
it.
think we're like just kind of starting to use it a little more from what I understand. I think we've used it before
It can be
last year.
used for actively dying children or for postpartum care. So it's a place, in fact, this week we had a child die very unexpectedly in the PICU. Very large family, so we were able to bring the child down to the reflection room so the family could have time with their child, and the family members could come in and say goodbye, and the siblings.
So it's like, oh, that's nice.
So
Rather
it
than
has a
ward or
little,
something.
it has the room with the bed, which also has a cooling blanket. And then it has a seating area, an area for kids to play, and a TV, and another one for and then a little kitchenette, microwave and hot water, snacks, things like that, and a refrigerator. So, but
And
you're
that's
welcome to
available-
come up and
That's
see.
available 24/7?
Available 24/7. The nursing supervisor can access it for anyone after hours, as well as the social worker on call.
Interesting.
Yeah. And I think anybody has access with their key card. We keep some memory making supplies there. If you run out, you can always have the nursing supervisor let you in to get memory making.
What is that?
We've got like the canvases to put the handprints, or the plaster things to make handprints or footprints, or for memory. Sometimes the parents aren't able to take it home with them at the time, so we'll keep them. Most often than not, they'll ask for it later if they don't take it home right when the child dies. Vivienne mentioned Moment by Moment. That is a nonprofit organization of professional photographers who donate their time and come and take photographs